fine.
Okay.
You can be brief too. No lengthy introductions needed.
Perfect. So thank you all for joining us this morning. I'd like to introduce Dr. Chris Buck, Dr. Andres Shindeli, and Dr. Alfu Pasanduka, who will be talking about advanced HIV in children in Mozambique. Dr. Buck is an associate professor of peds at DGSOM and the lead for the GHP's academic program in Mozambique, Brazil, KwaZulu-Natal, South Africa. Dr. Buck did his undergrad work at Wake Forest University Medical School, at the University of Northern Carolina, Chapel Hill, his pediatric residency training at the University of California, San Francisco from 2004 to 2007, and has a master's in public health from the London School of Hygiene and Tropical Medicine. After residency, he joined the Baylor International AIDS Initiative in Lilongwe, Malawi, where he worked from 2007 to 2013. He worked with CDC Mozambique from 2013 to 2015 as a national pediatric advisor and has been an in-country focal point for the UCLA Mozambique partnership since 2015. He's also a technical advisor for the Mozambique Ministry of Health in the areas of PEDS, HIV, PEDS TB, and drug-resistant TB. Dr. Pasanduka is a lecturer and faculty member in the Department of Microbiology at the University at UEM School of Medicine in Mozambique. Dr. Pasanduka completed his undergraduate course in general medicine at the Catholic University of Mozambique in 2007 and has a master's in public health from UEM. After graduating, he worked as a general practitioner providing care and treatment for people living with HIV in Maputo between 2008 to 2019. Since 2020, his academic focus has been on laboratory-based research of opportunistic respiratory diseases in adults and children living with HIV, which has been supported by the Fogarty Global Health Fellowship and a European and developing countries trial partnerships career development fellowship. He's currently working on a PhD at UEM focused on diagnosis of pneumocystic I'm so sorry if I butchered this, gyrovecchi infection.
There you go.
Thank you. In resource-limited settings. Dr. Andres Shindeli is a Mozambican-based pediatrician and researcher at the Department of Global Child Health at University of Witten, Herdecke, Germany. After graduation from medical school at the University of Leipzig, Germany in 2008, in 2014, he obtained his specialty in pediatrics from University of Basel, Switzerland, and a master in public health from the London School of Hygiene and Tropical Medicine. After work experience with Médecins Sans Frontières in 2015, in 2016, he moved to Mozambique to work as National Pediatric HIV Advisor for ICAP at Columbia University. He currently works for iTech Mozambique as pediatric HIV/AIDS and TB specialist with a special focus on pediatric HIV/AIDS, pediatric and multi-drug resistance TB, and pediatric malnutrition. I turn it over to you, and thank you so much for bearing with me.
Thank you, Vijeta, for the introductions, and yeah, good morning to everybody there. Really excited to be participating in the Selective and doing another one of the partner conversations. I think we've done this. This is the third year I think I've participated, and I think it's a great format for first-year medical students to get to know our program in Mozambique. I hope to generate some interest with some of you guys and hopefully have you here in the future for research or clinical electives, but also give you a chance to meet some of the colleagues with whom I'm working here in the country. So thank you to Alfeo and to Andreas for joining us. I'm going to try to be quick with my initial part because Andreas is taking this call from the airport and he has probably has to board a flight in about 35 minutes. So we'll try to get through his content so that he doesn't miss his plane to Johannesburg. So I'm going to share my screen here. Will somebody confirm? Can you guys see this?
We can see it. Thanks,
Vijeta. So we're going to be talking about advanced HIV disease in children and infants today. And our learning objectives, I want to first just start by introducing to the students what our Mozambique program and our partnership that also includes Brazil Then Andreas is going to take you through the definition and epidemiology of AHD in pediatrics. And he's going to talk to you about some of the programmatic work we're doing here in Mozambique to support the Ministry of Health with the National AHD program. And then we'll end with Dr. Pasanduka, who's going to talk about some of the collaborative research that's taking place between UCLA, UEM, and other partners in Africa and in Europe to kind of better understand what's driving morbidity and mortality in infants with AHD. So that's our content for today. I think it's important for you guys to understand Mozambique a little bit. Mozambique is as old as I am. We were both born in 1975. That's the year it got independence from Portugal. It's a Portuguese-speaking country. Unfortunately, the country was destabilized by a long civil war that started shortly after independence. And it destroyed a lot of the infrastructure that was left after the Portuguese exited the country. So when you think about Mozambique and everything that's going on here from a public health perspective, you have to think about this as a country that really just got its stable footing about 2 or 3 decades ago. And so in that context, it's easier to understand both the problems and some of the really impressive progress that's been made. There's a lot of optimism that the discovery of natural gas in the northern part of the country has the potential to transform this country from a low income to a middle income country. But that remains to be seen if that will actually happen. The population is now north of 32 million people, a large percentage of which are children. It's one of the poorest countries in the world in terms of GNI, and unfortunately, always ranks very low on the Human Development Index. Just to give a brief background on some of the child health indicators, there's high levels of chronic and acute malnutrition. Overall, vaccination coverage is improving, but not where we want to be for all things, including pneumococcus. There's an estimated 12.5% adult HIV prevalence. There's a high burden of TB and other infectious diseases, including malaria. I included the table on the right just to give you a sense of, it's hard to talk about Mozambique as a single place because it's a really big country. The coastline, in the Indian Ocean coastline is roughly the same length as the west coast of the United States. So we're in the very southern part of the country in Maputo, which is the capital. And you can see there, I highlighted that there was very little malaria in children in the survey that they did, less than 3% of children who were surveyed. But in some provinces in the northern part of the country, 2/3 of children who they randomly sampled off from their communities had malaria parasites in their blood. So when we do public health work in the country and even clinical work, it's a very diverse country with different realities in each province. If you compare our under 5 and infant and neonatal mortality in the United States, you will see why it's important that we're doing the work we do. There's just unacceptable differences in mortality in children and neonates in Mozambique compared to Los Angeles in the US. But the graph on the right shows that we have been making really important strides. Mozambique is the blue line, and the other line is all of Africa, to reduce childhood mortality over the last approximately 50 years, largely due to advances in vaccination and preventive health programs. And you can see in Mozambique the real rapid catch-up after the end of the Civil War. When we talk about things like HIV and TB, it's often you can end up with a negative impression of the country, but I always like to let folks who are learning about us know what a wonderful country it actually is. It's got a really interesting kind of colonial legacy from the Portuguese, great architecture, beautiful coast, really amazing food. People who come here never go back lighter than when they came, and really warm and friendly people. I've been here 10 years. Andreas has been here, I think, 6 or 7. And there's a lot of folks who come and choose not to leave. And so Alfeo is the only Mozambican on this call, but he can attest to that as well. The partnership in Mozambique started in 2008 when Dr. Miller established this partnership with both the Universidade Eduardo Mondlane, which is the principal public medical school in the country, and HCM, Hospital Central de Maputo, which is the principal referral hospital and academic hospital in the country. UEM and HCM are located on the same campus. Our program has different areas here. The core is really what we do in terms of patient care and medical education. And so we've had a full-time seconded faculty member on the ground in Mozambique since 2008. My predecessor was Emily Hartford, who's pictured in that first photo there, doing a Helping Babies Breathe training. I'm embedded as a faculty member here and do daily teaching on an inpatient ward and in the outpatient clinic, and oversee a really active learner exchange program with rotations for Brazilian, American, and European students here at HCM, in addition to sending trainees from Mozambique to different parts of the world for their own training. When I took over the partnership, we didn't have Brazil involved, and I recognized that there was big gaps in terms of language, and that many of our Mozambican colleagues weren't able to take advantage of the training opportunities that we had at Los Angeles. And so my faculty member is Karen Nielsen, my faculty supervisor, sorry. She's a pediatric ID doc, and she's Brazilian. And so she introduced me to some folks in Rio Grande do Sul and Porto Alegre. And we brought this other medical school, which we call PUCRS, into our partnership to better improve the quality of support that we're able to give our Mozambican colleagues. That map on the right is the world according to physician density. So it just kind of speaks to the real paucity of qualified physicians in sub-Saharan Africa, and the importance of leveraging, medical schools that have more resources to kind of help support other medical schools like UEM improve the quality of their education. We've worked in capacity building in terms of trying to build sustainable investments in training and medical equipment and IT resources and quality improvement in the hospital, both for patient care and for medical education. I don't know if any of you have met him yet, but pictured there on the right is Dan Diagarte. He's a pediatric surgeon who played a really key role supporting our Mozambican colleagues to get a pediatric surgery residency program started here in Mozambique. A big part of what I do is technical assistance work to the Mozambique Ministry of Health for the HIV and TB programs. And we have a long-standing funding from PEPFAR, which is the President's Emergency Plan for AIDS Relief, which is a program from the US that supports HIV activities in many high-burden countries around the world. And currently, UCLA is the lead partner to assist the Ministry of Health with the development and implementation of this package of services for children and adolescents with advanced HIV disease that we're going to talk more about today. We do research, and I'm not going to read all these, but everything that's posted there is a UCLA student or resident, is a project that involved a UCLA student or resident. So one of the things that we were doing a lot of is collaborative research between UCLA and our Mozambican colleagues, and something hopefully some of you guys will be involved in the future. So with that, I'm going to end my part and ask Andreas to take over and talk to us a little bit about first of all, he'll start with the epidemiology of HIV globally and then in Mozambique. Andreas, over to you.
Thanks a lot, Chris. So again, my name is Andreas. I am a pediatrician like Chris, and I came to Mozambique like 7 years ago. And frankly, for me, this is a dream job, what we are doing here. And I've been working with Chris for 5 years. So I first want to give you a more general introduction about the state of children with HIV worldwide and in Mozambique. And then we'll come to a more practical part, what we are doing in the area of advanced HIV disease. So we have an estimated 2.58 million children living with HIV globally. Of these, it's estimated that 150,000 are in Mozambique. So that means we have like roughly 7% of the children worldwide with HIV here. So if you look at this graph, you see two things. You see these gray bars, which is the percentage of pregnant women that are on antiretroviral treatment. And then you have this red line. And you see the red line, it has first stronger decrease, but then it decreases only very slightly. So whereas the gray bars, the percentage of pregnant women ARV, has plateaued. We continue to have a slight decline in this red line, which is the number of children that are worldwide still getting infected with HIV. So if you look, next slide, Chris, please. So if you look at this slide, this is the situation in Mozambique. So we see basically a constant increase in the total number of patients on antiretroviral treatment. You see these bars, the biggest part is a dark orange. These are the adults. And on top, you have this light pink part. These are the children on ARVs. And you also see, whereas 81% of the adults HIV positive are on antiretroviral treatment in Mozambique, only 73% of the children are. That means we still have bigger gap in children that are out there in the communities not on treatment as compared to adults. What you also see, you see the lines. Oh, sorry. Yeah, thanks. Okay, next slide, Chris. So now this is like, these columns are basically the backbone of our work of HIV program management. So the first is the total number of children living with HIV in Mozambique. So it's estimated that we have 150,000 children HIV positive. And so the backbone of HIV program management, you've maybe heard of it, the 95, 95, 95. That means of those HIV positive, we want to have 95% diagnosed. Of these, you want to have 95% on antiretroviral treatment. And of these, you want to have 95% virally suppressed. Yeah, that means they're taking that drug so well that they don't have disadvantages for their development anymore, and they don't transmit the disease anymore. So, but you see, if you look especially at the third column, those, we only have 73% of those estimated to be on HIV on antiretroviral treatment. These are these 112,000 kids. So there's still a big gap of children out there that are not treated. And if you look at the third bar, of those treated, 71% have viral suppression. This is still far from where we want to be, 95%. But if we see this is from 2022. 2021, we were at 51%. Next slide, please, Chris. This is basically a very interesting slide for us. It shows where is the big number of pediatric HIV infection worldwide happening. And there you see the big giant is Nigeria with 20%, but Nigeria also has a population of 200 million. We have around 30 million people. We are number 2 with 14%. This is very high. Yeah. Next slide, please. At the same time, you see that there are still many children getting infected in Mozambique. This is the percentage of children born to HIV positive mothers that get infected in Mozambique. And you see for 2023, we're at 10%. This is still high. We want to be definitely below 5%, but we are having problems to find certain mothers and get them on treatment. Many of the HIV positive mothers in Mozambique are very vulnerable. It's not an easy task. Next slide, please. So this gave an impression about the amount of work we have. And so the HIV programs over the past years have had a big focus to bring more and more patients on treatment, to get them virally suppressed, to get epidemic control. But then the past years, we noted there are still many patients HIV positive who are presenting with what we call advanced HIV disease, and they need specific care and treatment. Next slide, please, Chris. So in 2017, WHO published guidelines for the management of patients with advanced HIV disease, and this was a major step. And this is basically the base for a lot of our work, which we are implementing here in Mozambique. Next slide, please. So how do you define advanced HIV disease? The definition is to have a CD4 cell count less than 200 cells, or a WHO stage 3 or 4 event. What is a WHO stage 3 or 4 event? That is, for example, pulmonary tuberculosis. That is, for example, moderate or severe malnutrition. That's, for example, oral thrush. If you have one of these active stages, or you have a low CD4 count, you have HIV disease, and you should have specific care and treatment. Interesting, WHO considers all children younger than 5 years as having advanced HIV disease. Why is this? Because HIV, when it hits the immature immune system of very young children, it progresses a lot faster. So these children have higher mortality, they progress faster in the disease, and we need to consider this. Next slide, please. So WHO published in 2020 a specific package for children with advanced HIV disease, and it has this a slogan, "Stop AIDS." If you see on the top corner of the box 1, you see what does Stop AIDS stand for. It stands for Screen, Treat, Optimize, and Prevent AIDS. So this is the backbone of the package of advanced HIV disease for children that we implemented here in Mozambique. Screen stands for screening for mainly for opportunistic infections. And so there's the two big diseases, that is tuberculosis and cryptococcal disease. So TB diagnostic in children is a very complex issue. It is still a big challenge to diagnose tuberculosis in young children. So we got new tests with this advanced HIV disease package, which is the TB LAM. It's a lateral flow, small, tiny, easy to produce point of care test. Yeah. So you diagnose in the urine of patients, you diagnose disseminated tuberculosis. And frankly, we see it in our daily clinical work, often children in which the other tests, like for example, a gene expert, it was a PCR-based test, X-ray and other tests are negative, but in the urine, we find signs of disseminated tuberculosis. The other main agent is cryptococcal infections. So cryptococcal is a fungus that is definitely mortal for patients, lethal for patients when they have it. And so we also have a point of care lateral flow assay for this one, also very easy to use, that we are spreading all over the country to the major health facilities. So cryptococcal disease usually is very rare in children. It is more frequent in adolescents and adults. So we have specific patients in which we screen for this disease. So the second point is to treat. So we treat these opportunistic infections. An important point is that we have now drugs available like amphotericin B, even the liposomal version, so that we can treat cryptococcal meningitis. A few years ago, everyone had the diagnosis in Mozambique, practically died. It was difficult to treat, and drugs were not available. So the O stands for optimize. It means optimize antiretroviral treatment. These are certain drugs that are now first line, mainly dolutegravir. It's the new drug, which since last year we also have available for the youngest children. And we also think that this is a big part that helped us to get higher virus suppression among children with HIV. And the last part of the package is to prevent. So children with HIV should get certain prophylactic treatment. It's mainly the cotrimoxazole prophylaxis that helps against the pneumocystis jirovecii, but also against malaria, against many bacterial infections. Then we have TB preventive treatment, and we have cryptococcal meningitis and preemptive therapy. A big point not to forget is a big point is that the most frequent opportunistic infections in patients with HIV not on antiretroviral treatment are bacterial infections. So let us not forget that we have pneumococcal and conjugated vaccines also available in Mozambique. Here we have the one with the 10 seroglasses. And we have in the standard treatment also the treatment against Haemophilus influenzae. So these treatments are very important, and these vaccines are very important to prevent disease in our children. Next slide, please, Chris. So these guidelines, on base of the WHO guidelines, we developed advanced HIV disease guidelines for Mozambique. Yeah. So we did big parts of pediatric part of these guidelines. And now we're about to implement these guidelines. So what are parts of our work we're doing here in the Mozambique Ministry of Health? That is, first, we are training at our center, at our healthcare center. We are training providers from all over the country in advanced HIV disease, and specifically in pediatric advanced HIV disease. And our pediatric team is traveling all over the country to all the 11 provinces or federal states, to the major health facilities to help implement this clinically somewhat complex package for many of the providers here. And we regularly participate in technical working groups for pediatric HIV and pediatric tuberculosis, develop new guidelines, develop trainings, and train people. Next slide, please, Chris. So whereas Chris sees patient in a classical hospital setting, I see patients in an outpatient clinic, which is called CRAM. It's a very specific referral center. So the kinds of patient we have is patient with advanced HIV disease. So from all of Maputo, which has like more or less 2 million people, they send severe case of children with advanced HIV disease to us. Then we are a referral center where patients who fail first or second line therapy can get third line treatment. Then we are a referral center for multi-drug resistant TB. We have currently 15 children in treatment for multi-drug resistant TB. Doesn't seem so much, but it seems a lot when you consider that whole Mozambique had 60 cases over the past year. And apart from these three parts where we are very active, it's also home to up to now Mozambique's only harm reduction program where IV drug users can receive methadone and hepatitis treatment. So we have currently 162 HIV positive children and adolescents in care. Many of them are severe cases and are really at risk of death when they come to us. And as said, we are an important training center. So if you look at the picture, you see to the left side, Dr. Elsa. She's a Mozambican pediatrician, and we appreciate a lot her work. We learn a lot from her. And then, yeah, one of our patients. And this is our, you see, it's very basic. This is our place where we see patient in this small room. We have 2 desks. We have one for the provider and then one for a psychologist to take care of these. Good. Next slide, please, Chris. So this is the last slide of my part. So as I said, we've been working together with Dr. Chris Buck to implement package for advanced HIV disease all over the country. So since 2020, we've been traveling to the major hospitals of the country. So each of the 11 provinces has like a central referral hospital. And when you arrived there, in many hospitals, we saw people were not prepared. So in one of the big hospitals, for example, there were not even antiretroviral drugs available for children. And over the years, we saw amazing progress, which Chris is just about to publish in a very, very interesting piece. And so if you see, for example, let me just highlight some of these. So for example, if you look at the first line, when we arrived, only 5 of the hospitals had specific counselors who are there to test the patients. And now 10 of the 11 hospitals have them available. And if you look, for example, at the fourth line, when we arrived, only 4 hospitals had CD4 testing available. Now all of them have testing available. So these are big progress for the hospitals in Mozambique. And I think we really managed to strengthen pediatric HIV and advanced HIV disease treatment all over Mozambique with this. Thanks a lot, Chris. So this is, I'll leave it to Alfeo.
Thank you very much, Andreas. And since you do have a flight to catch, I'm going to pause and see if any of the folks have any questions or comments in case you need to leave early. I don't see any hands. Vegeta, is there anything in the chat that Andreas needs to respond to?
Nope.
Okay, Andreas, please stay on as long as you can, and if we miss you at the end, have a good trip, okay?
Thanks a lot.
All right. So now I'd like to pass the mic to Dr. Alfeo, who's going to talk about some of the research work we're doing regarding pediatric AHD in Mozambique. Alfeo, the floor is yours.
Thank you, Chris. Good morning, everyone. I'm Alfeo Passanduca, a member of microbiology team here in UM, and I'm very pleased to present the part of the result, the work that we have been doing here in Mozambique, both with Chris, that is one of my mentor from the Global Fellowship. Thank you. Next, please. I'm going to present the result from empirical trial, and this is a clinical trial that involves men of the country in Africa, and the hospital that Chris is working and the lab that I'm working now are involved also in this clinical trial. Next, please. Next, please. And this is the post that we present in CROI 2023, which shows the figure about mortality in African infant hospitalized with severe pneumonia and advanced HIV. As you all know, that children with advanced HIV disease have increased risk for development of increased risk of morbidity and mortality, and part of this death is related to the pneumonia, but the death rate of infants hospitalized with severe pneumonia are not well known. In this context is where the empirical clinical trials is being implemented. And this is a study with ongoing phase 2 and 3 open label randomized control trial, which is searching for the new approach for treatment of pneumonia in HIV-infected children by assessing the impact of empirical treatment against tuberculosis and cytomegalovirus. And the primary endpoint of this study is all cause of mortality at 15 days and at 12 months post-enrollment. And all children that are hospitalized with confirmed HIV condition in the age of 22 days to almost 1 year are enrolled in this clinical trial. And as you can see there are about 22 hospitals involved in this clinical trial. And we do follow up, we follow the patient enrolled, and we do a consultation in day 0, day 315, a discharge, in day 13, day 60, 90, and 100 and half a year, and at the end of the follow-up. For each involved infant, we follow them for about 1 year. And those patients that are enrolled in these studies are After enrollment, they are randomized for one of the 4 available treatment group. One of the treatment group that you can see by this randomization scheme is they receive the standard of care medication, and that standard of care medication is almost treatment for pyogenic pneumonia plus pneumocystis jirovecii. And second arm of treatment is the infant receives standard of care treatment plus valganciclovir treatment, which is treatment for cytomegalovirus. And third group receives the standard of care treatment and the TB treatment. And the last group receive all those available medication that trial, which is standard of care treatment, valganciclovir treatment, and TB treatment. And those patients after enrollment are followed up until 1 year. As the result by July 7, 2022, 310 patients has been recruited, and median follow-up was 4.5 months. As you can see by this recruitment follow-up in the bottom of this page, we have enrolled 312 patients, but for analysis, we include only 310 patients. As you can see there, of this enrolled patient, almost 78 patients died during the initial hospitalization, which totalized 25 of all patients in the cohort. And those discharged patients, which was 232 patients, which represent 75% of total cohort. 7 patients completed the study, which represent 23% of total cohort and 30% of the discharged patient. And in follow-up, there were 103 patients representing 33% of total cohort and 44 patients of discharged one. But 59 patients from these 232 patients, they died after hospitalization. And if we add this 59 patient with 78 patient, it totalized 138 patient who dies, all total in this follow-up. And this represents 44% of total cohort and 57% of death during initial hospitalization and 43% after discharge. And you can see that this we have been losing a lot of patients, and about in this Kaplan-Meier survival analysis, you can see that we lose many of the patients in initial hospitalization, particularly in 15 days of hospitalization, which can give us the probability of survival at 15 days about 71%. But even after discharge, we are still losing some babies. At the end of 12 months, the survival rate is about 20%. Next. As by this figure, we can see that there's still a gap in PMT-CT, ill infant diagnosis, and RT program to prevent infant from reaching very advanced stage of HIV disease, in this case with severe pneumonia. And we think, or we hope, that at the end of this study, empirical trial will bring some information about the survival benefit of treating empirical treatment against cytomegalovirus, also against tuberculosis disease. Next, please. This is one of the sub-studies that we are doing in this empirical trial. In this study, we aim to to identify the all-cause mortality. In this study, this is autopsy, minimal invasive autopsy. It is quite different from the classic one, which is open body autopsy. In this autopsy, we use the long needle to obtain sample and some fluid from the body. And the organ that we are sampling is the brain, the lung, and liver and bone marrow. And we are also taking the nasopharyngeal aspiration, and also as the cerebrospinal fluid to do histologic diagnosis and also microbiology diagnosis, hoping that at the end of the study we'll have a notion about what is the real cause of those children. And part of this sample are sent to Europe to do a histologic diagnosis, and some of them have been done in a seismos nearby laboratory here in Maputo. So I think this is the last one from my side, Chris.
Thanks so much, Alfeo. And I want to just congratulate you. For those of you who haven't known him very long, Alfeo has made amazing strides with his English. I doubt that he would have had the confidence to do such a great presentation a few years ago, but Alfeo, parabéns in Portuguese means congratulations, but great. He's been leading the lab part of this study and really doing an excellent job. And it was great to have him get the GloCal Fellowship and get support from the University of California to support his professional development. So before I do a few concluding slides, are there any questions or comments? Anybody have anything they'd like to ask Alfeo about the research results he presented? Vijeta, do you see any hands or comments?
None at the moment.
Okay. I see he and Andreas will both still be on the call, so maybe those will come up at the end. But so I just wanted to share with you guys a few thoughts about next steps and you know, a little bit about kind of coming back to you and where you're at your training and thinking back to when I was at an early stage in my career. But you know, I think what's been really interesting, you've heard from Andreas that there was this massification of treatment for HIV in the country and in the region. And what happened during that time period is that there was a big emphasis on outpatient treatment, and that we lost our focus on taking care of the sickest patients. When HIV treatment programs started in Southern Africa, only the sickest patients had access to antiretroviral treatment. You had to have a low CD4 or advanced clinical disease to access treatment. And fortunately, over the last 15 years, we've progressed and we've caught up with the Western world, and that we're now at a test and treat model where people don't have to wait to get sick to access treatment. And that's great for their health and for their long-term prognosis. But I think both Andreas and Alfeo also showed you that we're not over the hump. And despite our progress, we still have gaps in diagnosis, and we still have gaps in linkage to care, and we still have gaps even in the quality of care once people are on treatment. And the end result is that we still have children who are being born with HIV, and we still have children who are getting sick with HIV, and they're finding their way often to hospitals where we work. And so I think UCLA has a really interesting niche in Mozambique in that we're probably the partner organization or academic institution with the most inpatient pediatric HIV experience in the country. And so there's a number of partners whose work has been more focused on the outpatient sector. But I think we're really well positioned to do some interesting programmatic and research work moving forward to understand this subset of infants who are the most, infants and children who are the very sickest. And we're really happy to see this year that the WHO put out a policy brief to supplement the guidelines that Andreas shared with you earlier that look at that subset of patients with AHD but who are actually the sickest, and oftentimes they're in the hospital. And so I think there's recognition. If you look at those mortality data that Alfeo showed, they're just entirely unacceptable. And so first off, as he mentioned, we need to put as much effort as possible into preventing children from ever reaching that point. But for those that do still reach that point because of our programmatic shortfalls, we need to, at a clinical level, to know how to better take care of these kids and keep them healthy, or help them recover their health. So we're looking forward to, future research work and programmatic work to strengthen hospital-based care. You can leave this presentation maybe feeling a little bit doomy and gloomy about pediatric HIV in Mozambique, and we still do have our problems, but we have far more patients like this than we do sick patients. And if any of you have ever heard one of my HIV talks before to students, I often include these slides because I think it's important for this point in your training. But this little guy changed my life, not to be melodramatic, but I was a pediatric resident and I was planning to do neonatology and have a career in the US. And as a resident, I had an opportunity to do a month elective in Lesotho when they were starting their antiretroviral treatment program. And I met this kid, I did a consultation for him, and we actually were traveling on the same bus together that weekend. I look back in this picture and wonder what's happened to all my hair. But like I said, I was born in 1975. But the really remarkable thing about this boy is that this was the same child about 6 months before I went to Lesotho. The New York Times did a cover story about the pediatric HIV response in sub-Saharan Africa, and they focused on Lesotho. And they highlighted his story. He was an orphan who lived with his mother or his grandmother. I think he had to walk, several kilometers to get to the healthcare clinic. And you can see here, this is the face of pediatric AIDS. He was wasted. He was exhausted. You can see the sores on his scalp. And unfortunately, for those of us who worked in pediatric care in Africa, in the late 200s and the early part of the last decade, we saw way too many patients like this. And I'm really happy to tell you that, despite the fact that we are all still working on pediatric advanced HIV disease, these patients are much less common than we used to see in the past. And we see a lot more of these patients these days. And so it's interesting to work in a disease like this where, there can be such stark contrasts between health and sickness, just based on your access and your adherence to your treatment. And this is our end goal. We want to put ourselves out of business. But in your careers, as you guys pursue global health, you'll have a patient like this who really has patients who will have a profound impact on you, and maybe the choices you make about your career. I would have never guessed, if you had talked to me in my first year of medical school, that I would be living and working in Africa since 2007. It just wasn't anything I knew about. It wasn't part of my plan, but he helped teach me what the power of antiretroviral therapy, and kind of changed what I wanted to do with my career. So I'm very grateful to him wherever he is now. And with that, I think I'll conclude. Muito obrigado. Any comments or questions from you guys are very welcome, for myself or for Andreas or for Alfeo.
Hi, my name is Megan, and I'll be leading the question and answer section. I'm sorry that we were on the wrong Zoom link to begin with. I would have loved to introduce all three of you, but thank you so much for that. It was incredible, and your work is incredible, and we're all just so grateful to have you here this morning. So I'll call on Sam.
Hello. Good morning from the US. I don't know exactly what time it is in Mozambique right now, but just kind of giving my pleasantries. Thank you so much for your time, for giving this great presentation. I just wanted to ask a couple quick questions, one related to some of the specific things that past UCLA medical students that have come and worked in Mozambique have done research-wise or programmatically, like just to get a better sense of what specific things that we could help with or are working or could work on. And then also if you could speak a little bit to opportunities for cultural exchange, community engagement, things like that, when in country, especially as related to like the level of like language capacity and also just like exposure that would be needed and like opportunities to really engage with the culture and the community as well.
Yeah, thanks for those questions. You know, historically there's always been a fourth year clinical elective when folks right before or after match day, where folks will come for a month, and that's still ongoing. We had to pause it for a while during COVID, but that's a definite opportunity for DGSOM students. Before the curriculum revision, we had what they called the Global Short-Term Training Program, which was a summer research experience after the first year. Now I'm really excited about the new Discovery curriculum. I think it's a much better way for me to have meaningful research interactions with students. And so we're having our first 2 Discovery students come in January, and they're going to be involved in different sub-studies of the empirical trial that Dr. Alfeo presented. So their names are Joseph and Shannon, and if those of you are interested, you could reach out to them. They were here last year for their foundations experience, and we have 2 more foundation students coming next month. So really this new curriculum and this discovery opportunity is ideal for folks who want to come and get involved in our research. We have a big research team that works here, and I like this partnership model. So I'll always try to pair UCLA students up with Mozambican residents or other learners and kind of have them work side by side. I think it works best that way. The biggest challenge for students here is definitely the language piece. I'm not going to lie. It would be easier if I was in Malawi or South Africa. But it is what it is. Folks who haven't spoken any Portuguese have come by and have come and had good experiences. Those who speak Spanish have a leg up. And I've had a few who actually speak Portuguese. But if someone's really interested in the type of work that we're doing here, I would encourage you to reach out to me and we can chat. I wouldn't want you to, have the language going to be an absolute barrier for you. I see Andreas fell off the call. I wish he was here for the social integration thing, because I joke with him. He's like our social ambassador. He's a very active guy, but Maputo is a really cool city, man. It's like vibrant. There's a lot of good stuff going on. The students who come, I think they've made friendships and kind of found ways to go out, get dinner, travel locally. We're really close to South Africa too, so folks often will take advantage and get to Kruger for a safari or something like that for a long weekend. But one of the things that I consistently get positive feedback from all the students who visited is about how much they enjoyed their time in Mozambique. We haven't had issues with safety, and I think they all made some really good friendships while they were here. So it's a selling point.
Thank you so much. I appreciate it. Also, is that Joseph Burcell, by the way, who's coming?
Joseph Burrell is coming, yeah.
Wow, yeah, okay.
And Shannon Richardson are the 2 students who are coming in January.
Yeah, I had a conversation with Joseph actually before I even got into UCLA about this program. So just kind of rung a bell who's actually like coming. But yeah, thank you so much. Appreciate it.
You're welcome, Sam. Thanks for your question. Any others, Megan?
I don't see anyone raising their hand, but if nobody has a question, I can ask a few. So what was one of the hardest things that you've experienced working in global health, and like a lesson that you've learned from that we could maybe benefit from starting our careers in global health now?
I might take you guys, you might be late to class if I answer this fully, but my career path has been quite interesting, and it's interesting when you're, up to this point in your lives, it's been very regimented. You went to primary school, and then you went to secondary school, and then you went to university, and now you're going to be in medical school for 4 years, and then you're going to do residency. And then when you finish residency, that goes away. Some people will do a fellowship, but I went to Malawi as a newly trained pediatrician, and I didn't really know exactly what the path in front of me would be. And I really started out doing a lot of patient care and healthcare worker training. And then as I gained experience and I formally studied public health, I kind of transitioned to more of like a kind of higher level country public health advisor type role. And it's only later in my career now that I've kind of pivoted to be more of a researcher. And I think to get back to your question, I think the challenge was maybe not knowing exactly what that path would be, and kind of figuring out what the niche that I wanted to fill would be. But the great thing is that, and the MD degree that you guys are going to obtain is super flexible. And it's something that will open doors for you guys to do, whether you want to do advocacy work or whether you want to do research type work or training and clinical work. So I would say it's been a challenge, but it's been not a negative challenge. It's been fun to kind of evolve and keep my career fresh, take on new challenges as, I've gained experience. And so now I'm at this point where I'm kind of looking at the end or the second half of my career and trying to think a little bit about what my next step will be. And I still don't have it figured out, but I'll be interested to see where I'm at 5 or 10 years from now.
Thank you so much. So it's just like being okay with unknowing of next steps kind of thing.
Yeah, and for students, one thing is I always tell students when they come visit is that I've had some in the past who felt a lot of pressure that they needed to contribute something really big. And I think as you guys think about your global health experiences in this point of your training, it's okay to recognize that it's probably not the time when you're going to be making your biggest contributions. And selfish is the wrong word, but it's okay to be a little bit self-centered with some of your early experiences, because what you're doing is nurturing your interests and you're gaining experience so that when you're fully trained and better positioned to go and make long-term impact, you will do so. So I always, all the students who come have had an impact. They've helped with teaching and everything, but I always tell them to not stress out about that and to come and to soak it all up and absorb and learn, and then come back to me in 5 years and tell me what you're doing after you finished your residency training,
Awesome. Thank you so much. And we have one question from the chat from Marlena. You mentioned the language was a big barrier in the beginning. What is the best way to learn the native language when working overseas?
Yeah. So Alfeo and I work with there's a lot of Cuban doctors in Mozambique who manage, just on Spanish. So I think the most relevant thing for DGSOM students would be to work on your Spanish, because that'll help you in your medical school and residencies in California. And if you have that kind of Romance language base, it helps a lot. For those people who know they want to come and work in Mozambique or know they want to go to Brazil, I would ask Tracy Wells or some of the other folks in the GHP program. I know there's different apps and different training courses that people have done. But Alfeo, what's your impression? Do you think folks who speak Spanish, we can usually understand them and they can understand most of what we're saying, I think. Don't you agree?
I think so, yeah.
We call it Portañol, the people who speak Portañol.
Portuñol.
Any more questions from the group? If not, I don't know how much time we have left. How about?
I think we're 4 over.
Yes, we are already 4 minutes over. So I think if there's no more questions, Megan, I think we're good to go for today, because I know you guys all have class now.
Thanks.
So much.
Yeah, thank you very much for the invitation, Vijeta. Thanks for organization, and please feel free, Megan, to any of your colleagues who want to reach out to me. Vijeta can give you guys my email address, and I'd be happy to set up one-on-one meetings with you. Okay.
Thank you so much. You're doing such important work, and we're so grateful for both of you, all 3 of you, for empowering us to do similar work and get involved in this.
Cool. You guys have a great day. Okay.
Bye.
Thank you. Bye.